we're going to run a little bit through some of the literature on this. Internationally, neoadjuvant endocrine therapy is something that's severely underutilized. I think for some of the most recent papers looking at sort of usage says about 3 to 4% of patients get access to neoadjuvant endocrine therapies, which is a very small percentage, taking into account that 80% of our cancers are estrogen-positive tumors. So I'm going to review the literature a little bit in terms of which options should we be thinking about, which patients should be considered to treat, how long should be treating. There's a lot of new data actually, and a lot of new direction in terms of neoadjuvant therapy. And then lastly, just there's some practical applications. I think if you want to read maybe sort of two good meta-analyses. This is one I think from 2016, which really looks at most of the trials that happened up until maybe 2015-16, and then this is a more recent meta-analysis that incorporated some of the newer trials. But I think the one thing I want to say about this is, let's put that out there, is that if you look at patients that are estrogen positive, the survival in patients who receive neoadjuvant chemotherapy versus patients who receive neoadjuvant endocrine therapy are exactly the same. So we're not saving more lives by using chemo instead of endocrine therapy. I think people tend to think that if we use something that seems more aggressive, that we can have a better outcome. So I think that's the first important thing. So if we compare neoadjuvant endocrine therapy to chemotherapy, there are a number of trials that have looked at this. And maybe just one step back is, again, if we are using neoadjuvant, I mean, we are very used to doing neoadjuvant chemotherapy, doing surgery, and then continuing with endocrine therapy. But somehow it's sort of this strange feeling of, if you do endocrine therapy, then do surgery, and then do adjuvant chemotherapy, it's like, oh, wait a minute, what's happening here? So when we discuss neoadjuvant endocrine therapy, it does not exclude the use of adjuvant chemotherapy in these patients. So, and most of the trials look at 4 specific things. And again, when we talk about neoadjuvant therapy in the context of triple-negative cancers and HER2-positive cancers, complete pathological response has become sort of the marker stone of how we gauge these trials. So it's always in the trials as one of the things. But if we look at clinical response in trials that were done before 2016, and there were about 27 trials. In fact, if you search for neoadjuvant endocrine therapy, you're probably going to get about 270 publications on that. If we look at trials that were done prospectively or controlled trials, we're ending up with about 27, of which about 20 are trials that have got good data to work with. Some of them were combination trials with chemotherapy, some were endocrine therapy. So this was basically looking at endocrine therapy versus chemotherapy in terms of clinical response. And here you can see almost equal in terms of the outcome if we look at the average there at the bottom. If we look at radiological response, and again they used a lot of ultrasound, they did use some MRI, it seems to favor chemotherapy. But as Jester said, the radiological picture does not always equate to the pathology that we find in the end. If we look at pathological complete response, chemotherapy is definitely better, and we know that from most of the trials that have looked at that. And we seem to say, well, because pathological complete response is such an important determinant in patients with triple-negative breast cancer and HER2-positive breast cancer, it is important. But in the context of a patient that's a luminal A or B, that specific, whether the patient has a complete response is not as important in terms of survival as it would be in the other groups of breast cancer patients. I think the big issue comes in terms of breast conservation therapy. If we can improve breast conservation rate by 30% or 40%, that is a significant impact for patients. It is less expensive, less complicated to do. So And if you add, this is in an era where oncoplastic surgery was not well established. So these figures should certainly be a lot better in today where we're doing oncoplastic techniques on a much more wider scale. So definitely chemotherapy versus endocrine therapy. The biggest thing for me is you can save more breasts by doing it that way. There's some newer trials. This is a fairly small trial, 140 patients, again looking at outcome, recurrence risk, exactly the same if you compare chemotherapy to endocrine therapy. And this is probably the most recent published trial looking at about 6,000 patients, of which 850 received neoadjuvant endocrine therapy. And again, in terms of 10-year overall survival, no difference. So I think if you ask the question is, am I saving more lives by doing chemotherapy versus endocrine therapy? The answer is no. Am I saving more breasts? Most likely yes. The next question is, which agent should we be using? And obviously tamoxifen was the gold standard for probably 30 years. Then AIs came along, so there are lots of trials that compared those two. And you'll see now in terms of clinical response, it favors the aromatase inhibitors. If we look at radiological response, again, AIs are favored. Pathological complete response, not such an important marker. And most of the trials, you would find complete response rates of maybe 2% or 3%. So very, very low rates of pathological complete response. But AI is definitely better at that. And I think when I start talking a little bit about the newer directions, you'll see that we could actually improve on that quite substantially. In terms of breast conservation, again, an additional sort of 20% improvement if you use an AI over tamoxifen. So definitely, if I have to choose between an AI or tamoxifen, an AI is always the better option. We'll talk a little bit about menopausal status now. Most of these trials were postmenopausal patients, but there were some of these trials that included premenopausal patients as well. There's some new data coming out on fulvestrant in the neoadjuvant setting. This is basically just sort of a dose trial to see, does it make a difference if you give the patient 500 versus 250 milligrams? And in principle, there is you'll see there's a sort of theoretically a 30% increase if you use a higher dose, but because of the small number of the patients, it wasn't significant. So we don't think that in the neoadjuvant setting in fulvestrant would make a big difference in terms of dose. If we compare that to anastrozole, again, fairly small numbers. We don't have big trials on this. There's a very small difference, and in terms of statistical significance, no difference between the two. So we can basically, it looks like fulvestrant would be about similar in terms of its breast conservation rate and its response rate if we compare that to AIs. How do we select patients? And I don't think we probably don't have to say that, but you wouldn't give endocrine therapy to someone that is not estrogen or progesterone positive. So I think that is sort of a given. We'll look a little bit about the role of Ki-67. We'll talk about the PEPI score and maybe mention a bit about the genomic markers in terms of how do we decide which patient would be an appropriate patient to treat with neoadjuvant chemotherapy. And I think all the trials have said if you have an LRAD score of 2 or less, or if you have an estrogen-negative patient, then it's not an appropriate option even to consider. But looking at some of the larger trials, the initial trials that were done really were quite big trials, and that showed that even patients with what we would consider low levels of estrogen expression, less than 10%, still actually benefited and responded to therapy. And I think it wasn't the Larson Garland, the one before that, there was a panel discussion, and the feeling was that patients that have an estrogen percentage above 1% should be offered the option of endocrine therapy. In terms of whether you should be using neoadjuvant therapy for that patient, I think one can argue about that, but one shouldn't exclude the fact that the patient's ER isn't 100% and not thinking about the option of neoadjuvant therapy for the patient. I think the one thing that the trials have shown is that if you have lower levels of estrogen expression, tamoxifen loses a lot of its efficacy. So AI is not as much, but I think that's one thing to keep in mind is if you have a patient with a lower level of estrogen expression, then really AI becomes more important. Ki-67 obviously has become a mainstay of how we try and classify cancers. But I think in the neoadjuvant trials, interestingly enough, the initial level of Ki-67 had absolutely no correlation with recurrence-free survival. So, and that's something we tend to use every day in patients that we diagnose and then operate, or diagnose and then give chemotherapy to, is we make decisions on treatment based on that initial Ki-67. But in a neoadjuvant setting for the endocrine therapy, it doesn't seem to correlate well with the patient's outcome. And whereas the post-treatment or the post-exposure level of Ki-67 has got a very, very significant correlation with recurrence-free survival. So I think the important part is we can improve our predictive value of Ki-67 by actually exposing that tumor to endocrine therapy. That prompts us to say we should be using it much more often in terms of assessing that response. And the question is, how long do you need to treat the cancer with an endocrine therapy to get that response? There's at least one trial that looked at Ki-67 after 1 week of tamoxifen exposure with equal predictive value. Most of the trials have looked at anything from 2 weeks up to actually 24 months. So there's a very wide range of evaluating the Ki-67 response after endocrine exposure. I think most of the current trials and most of the sort of current thinking is that you probably should retest that tumor somewhere between 2 and 4 weeks. That'll give you an early answer. If you want to make a decision whether I'm going to swap from endocrine therapy to chemotherapy, then a rebiopsy at 2 or 4 weeks is probably warranted. And the idea is that I think there are two main things in the literature that we look at. The one is to try and, if you want to see that there's a significant response, then that Ki-67 should drop down to under 10%. If you want to see whether the patient has a complete cycle arrest of the tumor, then it should drop down to less than 2.5%. So those are the two sort of figures that we want to look at in terms of response to the neoadjuvant endocrine therapy. So they try to see, can we maybe incorporate all of this into a scoring system that would predict patients that actually require adjuvant chemotherapy. So the PEPI score was developed to say, okay, we are going to do this after surgery. So this is number one, patients who's now completed endocrine therapy, then have surgery, and then we have to make a decision, can we just continue with endocrine therapy or should we actually add adjuvant chemotherapy to this patient? And they used the pathological staging of the tumor after exposure to endocrine therapy, the nodal status, the Ki-67 level, and the ER status, and basically looked at what would be the hazard ratio if you would have specific factors, and based on that you would then develop the PEPI score. And basically you have three degrees of risk. If your score is 0, you have a relapse rate that's less than 10%. If it's between 1 and 3, your relapse rate is 23%. And if you have a score of more than 4, it's 48%. There's fairly good clarity that if it's 0, you don't have to add chemotherapy. And if it's more than 4, then you definitely have to. There's a little bit of a gray area in this 1 to 3 group, and I think that's the group that probably warrants a little bit of individualization. There was one group that said if we add the progesterone receptor into this mix, we could actually add an extra level, and you can see here on the slide that if you used 50% expression level as a cutoff point for progesterone, and you added that, so they took the PEPI score and they just added this progesterone level into that as another marker, and they said if your score is 1 to 3, then your risk of recurrence is exceedingly low. You can see that there's not a huge, there's 49 cases, which they had no events in over the course of time. If your score is a high-risk score, more than 7, you can see that the survival rate or the recurrence-free survival rate has dropped very significantly. So again, it adds a little bit of extra prognostic value for the high-risk group if you add that into. So this is something that you can utilize if you've treated the patient with endocrine therapy, had surgery, and now you need to decide whether to continue with chemotherapy. We do use molecular markers. There's a few trials that are using PAM50 as the marker. In South Africa, well, we don't have access to that. We use BluePrint, which is part of the MammaPrint package, if I can call it that. And interestingly enough, when we utilize this, and we will see that we change the molecular type of the tumor in about 22% of patients. That's 1 in 5 patients where you change what you think the tumor is. And most specifically, tumors that you thought would be a luminal tumor that end up being HER2 positive or a basal type, or patients that you thought were HER2 positive that ended up being a luminal A. So, and so it is exceedingly valuable to use this. The big problem or the big challenge that you often have is, if I want to do neoadjuvant MammaPrint, is I need to know what the extent of nodal disease is, because these things have been validated in patients with nodes of 1 to 3. So I tend to, in these patients, consider the option of doing a sentinel node biopsy before we actually do the endocrine therapy, because if the patient has 5 or 6 or 7 nodes involved, most guidelines would say that patient really does require chemotherapy. So to just summarize this, we're not saving lives by doing chemo versus endocrine in the neoadjuvant setting. We still have the option of doing adjuvant chemo. Pathological complete response does not play a big predictive role in terms of the patient's outcome, but breast conservation rates are a lot higher if we use endocrine therapy. Baseline Ki-67 in the neoadjuvant setting really plays a very small role, but it is really important to see what the response to Ki-67 is. And in our clinic, I always say, if you have a tumor that is being driven, that has a proliferative stimulus like HRT, or in a premenopausal patient, you would expect that that tumor would have a proliferation of 30%. When you switch that off, that's really what tells you whether this is an exceedingly estrogen-driven tumor or whether there are other kinases that drive the tumor's proliferation. And AI is definitely more effective than tamoxifen. Just quickly have a chat about menopausal status. I think most people would agree that neoadjuvant endocrine therapy is something that you really should consider strongly for postmenopausal patients. But we do have data in premenopausal patients, and we do have some benefit in them. It's just that the body of evidence is a lot less. So this is one that had close to 200 patients that were premenopausal, and now the important part comes in that these patients need to have ovarian suppression as part of their treatment strategy. So the use of Zoladex in this situation, you can see 24 weeks, so that's sort of a 6-month treatment period. And again, looking at tamoxifen with anastrozole, most certainly the AI gave much better results. And in terms of breast conservation, you had a 42% versus 58% breast conservation rate. 69 versus 86%, sorry. This is another trial, but this trial included both neoadjuvant chemotherapy and endocrine therapy. And I think what's really important here is there's actually several trials. I think the dictum has always been that you can't use endocrine therapy simultaneously with chemotherapy because you are arresting the cell cycle, and therefore the chemotherapy is not going to be effective. But here's a trial where they actually did utilize that and actually showed an improved response in the patients that had combination endocrine and chemotherapy. So, and it was most, and again, I'm coming back to this Ki-67 now, they used the baseline Ki-67, so that progression-free survival benefit that we're seeing, and you can see that's quite a significant difference between the two groups, was mainly seen in the patients who have a high proliferation index to start off with. These were all premenopausal patients. So I think it is also something to keep in mind in terms of our thinking about, selecting patients that, you can actually combine the two with one another. So how long do we need to treat patients for? I think a lot of people trained or grew up in an era where like 3 to 4 months of endocrine therapy was considered to be enough. But the reality is there are quite wide variance in terms of trials, ranging from like 1 week even up to several years. I have had one patient that, by default, it was a premenopausal patient in her 30s. She refused chemotherapy. She refused surgery. She was willing to have a Zoladex injection and had Tamoxifen. And I operated this patient 18 months later after trying, convincing her, and she had a pathologically complete response, and she's now 9 years down the line without any recurrence. So the reality is we do occasionally see these patients that really respond tremendously well to endocrine therapy. And in terms of the duration of treatment, I think there are two things here. It depends a little bit on what do I want to achieve with that. So if my aim is I want to shrink the tumor as much as I can, then longer treatments are probably going to be the way to go. So we should be considering treatment lengths of probably more than 6 months. I think 3 to 4 months, both from the literature side and my personal experience, is definitely not long enough. People tend to get a little bit apprehensive, if after 3 months they don't see the tumor, growing down to 1 centimeter, and now they want to jump in with surgery. I think that's where maybe a rebiopsy might be an option, see what the Ki-67 does. But in principle, there are small trials that looked at longer durations of therapy, and this one was only 32 patients, but they saw a progressively better response rate as the time went along. This is another trial, a little bit larger series. They looked at 3 months, 12 months, 24 months, and again, they saw better responses in patients that had longer therapy over the course of time. Probably at 12 months, they saw the biggest response. This, again, another trial. They looked at 4 months, 8 months, 12 months, treated patients with letrozole, saw maximal response at about 12 months. And you can see this was the observed response rate, 95% at 24 months, 86 and 45 respectively, and breast conservation rate also improved progressively over time. So this was a trial that just looked at when did you have the biggest effect, and they found that the mean duration for treatment was 7.5 months. So I think looking at the trials, my feeling is we should be treating patients probably between 6 and 12 months if we want to achieve really good tumor shrinkage with the intention of doing breast conservation treatment. So I think there's the thought process going on is to say that if we can in some way control the tumor's growth a little bit better by doing some sort of dual blockade, we might do better. We could maybe combine endocrine therapy with chemotherapy, and I think at the very least what I can say is that endocrine therapy with chemotherapy does not negatively affect the tumor response rate. So I think those are the things that have come out quite recently, and now we're seeing all these new trials coming out that are now looking at dual blockade, and we're seeing a very significant improvement in what we can expect. So these are all trials that are using AIs, and some of them are combining them with CDK4/6 inhibitors, and some of them are targeting the PIK3CK or the mTOR pathways to try and see, can we block that pathway in more than one position. They use different endpoints, different ways of measuring this. The idea is to see, can we arrest the cell cycle completely? As I said, Ki-67 that drops to less than 2.5% generally means that this tumor has stopped growing completely. C1d15 is a surrogate marker for cell cycle. Lots of the trials are using proliferation index of less than 10% as the outcome. And then we have some at the bottom here that you'll see basically looking at clinical response or overall response that we're looking at. But in principle, you'll see that adding some other agent in terms of the cell cycle all has additional benefit in terms of the outcome of these patients. So you can see by adding Palbo to the anastrozole, we're going from an 87% to a 26%. So we're switching off that cell cycle completely in most of these. And I think this is the type of data that we're seeing in most of these new trials. They're all fairly small trials, they phase 2 trials, but I think this is probably where we might be heading in the future, is to sort of start using these combination therapies in patients. Again, you'll see pathological complete responses very low in these trials. So the aim is not to try and achieve a complete pathological response, but to achieve a tumor that becomes more operable and have tumor control over a longer period of time. The same goes a little bit in HER2. I think the dictum is that HER2 positive cancers are almost inherently estrogen resistant. That they all need to have chemotherapy. But the reality is there is a lot of in this triple positive group. It's a very heterogeneous group of patients. It's been a little bit of a pet project in terms of looking at these HER2 positive, ER positive tumors, because it seems like a lot of them are behaving more like luminal A tumors. And the question has always been, are we adding value by adding a lot of things like chemotherapy and HER2 treatment? In our clinic, we frequently have these patients that have a HER2 ratio of 2.0 or 2.1, and they've got a proliferation index of 5%. And the issue is now, should you be treating those patients? So these are all difficult questions. There's no really good answers. There's a lot of literature that says they don't respond very well to chemotherapy, but the guidelines generally still suggest that you treat them as such. So if we look at how they integrate with one another, you can see here that both the HER2 pathway as well as the estrogen-driven pathway, there's a lot of crosstalk between those two. So if you then block, let's say you do HER2 blockade, and we all know that trastuzumab as a single agent treatment, for example, really poor responses. Even trastuzumab combined with endocrine therapy, with tamoxifen. So, and you can see why, because you can see that even though you're blocking this pathway here, because you've got this cross-stimulation of the proliferation drivers, the cell cycle continues. If you want to arrest that, in theory, you have to actually be blocking both of those. Now, this now comes back to this question, would we get better results if we combined anti-HER2 chemotherapy and endocrine therapy in these patients versus just targeting one of these pathways? The idea with chemotherapy is that you want to arrest the cell cycle and use the HER2 pathway. So, and this is why we're seeing, in some of the trials, the GERPAR trial, at close to 6,000 patients, the pathological complete response rate in the patients that were luminal A patients were under 2%. So the reality is, if you have a tumor that is HER2 positive but strongly estrogen driven, the response to anti-HER2 and chemotherapy only is not that great. So there's a couple of trials that have actually looked at this, and you'll see it's a very sort of mixed bag of things. This is a trial that looked at TDM1 with tamoxifen or an aromatase inhibitor. So the problem with a lot of these trials is that the choice of drugs that we used were maybe not optimal in terms of what we want to try and achieve. And that, again, if you're using pathological complete response as your endpoint in an endocrine positive tumor, you're probably not going to get a true reflection of what's happening with the tumor. So you'll see that is an issue with these trials. So at the very least, the thing that I can say about this is that adding endocrine therapy to your anti-HER2 treatment, in none of the trials it made the response worse. In all of them, it made the response better. So I think that's the first thing. Unfortunately, you'll see PCR, PCR. So I'm not sure that in terms of choosing the endpoint for the trial, I understand that in HER2 positive cancers, that's what we want to look for. But if you have trials where you're using no chemotherapy, using only HER2 targeting and endocrine therapy, PCR is probably not the best thing to look at. You can see in this trial, they actually used the PAM50 to do molecular subtyping, and you can see here that if the patient was a non-HER2 enriched subtype, they only had a 5.3. I see my little marker is not showing up on the screen, sorry. So in that top block, you'll see there, within the HER2 positive disease, pathological complete response rates were 31.6% in HER2 enriched tumors. But if the tumor was a non-HER2 enriched tumor, the response rate was only 5%. So I think that is, for me, quite a critical thing. That these are not all the same tumor in terms of its molecular typing. This one actually looked at differences in proliferation that occurred. And we can see that there's a very significant drop. So if we just look at proliferation, it seems like the combination of this is fulvestrant with trastuzumab and pertuzumab. So you can, with palbo added to that. Now, and this is in a HER2 positive patient group. So we're seeing that in this in this triple positive group, that there's a lot of interaction between the two. And I think that's an area that needs to be explored quite a bit. The last thing in terms of new data is we always used to say that breast cancers are non-immunogenic tumors. We don't use immunotherapy in estrogen positive tumors, but data actually suggests that when you start the patient on endocrine therapy, you're actually upregulating and actually creating a very, very significant immune response. So now data suggests that these are probably some of the most immunogenic tumors that we have if you expose them to endocrine therapy. So it causes an influx of natural killer cells, and it also creates an increased expression of PD-L1 on the cell surface. So by adding neoadjuvant chemotherapy, you're actually making a tumor that is fairly immune stable into an immunogenic tumor, and that opens up the option of then maybe adding immunotherapy into that initial treatment of the patient. So these are all trials that are currently recruiting or currently in planning phase in terms of ER-positive breast cancers, where they want to now look at this option of starting off, and you can see again, some of these are using tamoxifen, some of them are using fulvestrant. They're starting with locally advanced. There's some. So these are all trials that I think in the next 4 or 5 years we're going to start seeing some data coming through. So for me, that's a very exciting part of it, is that we are going to start exploring this fact that we are generating a tumor that is going to be much more susceptible to that. So coming back to the practical part of it. Traditionally, the idea was we can make tumors more amenable to breast conservation therapy. And so you had a patient that wasn't a candidate for breast conservation. They were probably not a fantastic candidate for chemotherapy. They were postmenopausal. They had tumors that ranged anything from a T2 to a T4. And they were ER or PR positive and HER2 negative. So this is the sort of classical selection criteria for a patient that you would do neoadjuvant endocrine therapy for. And the patient would then have, you would look at them and you say, okay, Ki-67 is 30%, We're going to start you on treatment. I'm going to repeat the biopsy in 2 or 4 weeks. I'm going to see if your Ki-67 came down. If not, I'm going to put you on chemotherapy. If it does come down, we're going to continue with endocrine therapy, and we're going to wait for surgery. And traditionally, 3 or 4 months, but probably now we'll say 6 to 12 months later. Coming back to the whole issue of clips, it is the bane of my existence is radiologists or patients that have biopsies and don't have markers in nodes that are positive on initial imaging, and then doesn't have a marker in. So if we can change that, that would be wonderful. So we have a written protocol in our meeting for which patients get what type of marker. So anybody that wants to have that protocol, they're welcome to send me an email and I'll send it to them. But the idea is that you want to then, the aim of this whole thing is I want to create someone that can have breast conservation therapy. I think the thought process of saying, but maybe we need to change the way we think about this, because now in this modern era, I see a patient that comes, every patient under the age of 50 gets a genetic test. That is going to take 3 or 4 weeks to get that result. Any patient under 60 that has one relative with breast cancer gets a genetic test. It takes time. It takes 2 weeks to wait for a FISH test. It takes time to do the staging. It takes time to wait for oncoplastic and whatever. So, we need time to schedule with the plastic surgeon. So there are lots of stuff that needs to happen from the day the patient gets diagnosed with breast cancer until something happens with that patient. Traditionally, that happened in the surgeon's office, so no one knew about that. Okay. And how can I say, the treatment starts when the patient sees the oncologist. But the reality is the patient was diagnosed with breast cancer a month ago already. So the question is, they talk about window of opportunity trials. It is a window of opportunity that we can do something to the tumor that gives us additional information about the tumor. So we're also dealing with, I'm not surprised to see patients in their 90s more and more frequently. We operated a patient 3 weeks ago that's 99. So this is the problem. It wasn't for a breast cancer, but the reality is we are seeing these patients that are really surviving quite long, and that taniki is, bright as a bird. So anyway, so the idea is to say, right, we have a biopsy, we have a baseline Ki-67. Those things have become sort of standard in terms of what's available to us. And we start endocrine therapy almost routinely in these patients, in most of these patients. These are generally early breast cancer patients that now present to you. You then do all your staging, your genetics, whatever you need to do, and the patient has surgery. If you're not a very busy surgeon, a week later. If you're a busy surgeon, maybe 8 weeks later, doesn't matter what. But the reality is the patient has been on treatment for a breast cancer on day 3 or 4 after diagnosis, in theory. She hasn't been waiting for nothing to happen. When I do the surgery, I have a second view at the tumor. I have an opportunity to look at the biology of the tumor at that time frame, and it gives me additional biological information. It's a little bit like launching a missile, to the Russian camps in Crimea and then seeing what happens on social media. Same thing, We've launched the attack at the tumor, we see what the damage is, and based on that information, we now make decisions about what is the most appropriate treatment. And the reality is, if we use that pathway, we can get that initial prognostic information, not just static morphological information that we are used to. Breast cancer is a biological disease. It's not a lump. I always tell patients, no one ever died of a lump. Okay. Number 2 is, it's really cheap to do. Okay. And we can probably save 20% of the patients that would have received adjuvant or neoadjuvant chemotherapy from having chemotherapy. So cost-wise, again, a big cost saving, morbidity-wise, So those are the benefits that we have. So it would be my contention that we should be using this window of opportunity to treat these estrogen-positive patients early on in their diagnosis so that we can gain those benefits. We will still have some patients with locally advanced tumors that we want to downstage the tumor to make it more operable. But a majority of our patients will fall into this first group that would actually have the opportunity to gauge the biology of that. That's my story.
Thank you, Ettienne. That was brilliant. I think that was a very, very good overview. Bringing in all the new things, it's a lot of stuff that we know from before. But I agree with you, we should put all our patients on this and say, we at British Care, we've been putting our patients on it because we had no other choice, because our waiting times were so long. We can't get a patient operated at 8. Now, even our waiting times are 10 weeks sometimes. So we put patients on this, basically just so that we feel we're doing something, but we're actually doing a lot. But you should then look at the key. You should routinely do the key on those patients afterwards when we do the surgery, so we get that information and we can use it. If that key is dropped right down, it gives us a lot of information.
And I see a lot of patients where you operate them and it's 1%. So and that, for me, that's really what you want to achieve, is you want to see that patient. It doesn't really matter so much for me whether the tumor shrunk that much. It usually does, but occasionally it's maybe 50% smaller than what we started off with. That's fine. But if it went down from 20% to 1%, that's a patient that's going to really do exceedingly well in the long run.
And that's almost the same information that you get from complete pathological response in a triple negative patient. That patient is going to do well. That patient is going to be fine.
So I think in terms of trial endpoints, that is what the trial should be looking at, is less than 10% and under 2.5%, because that gives you much better information than looking at a pathological complete response.
Any questions, comments from the floor? Oh, there we go. Hands up. We had lots of time. That's why I gave an hour for these two talks, because I think this is where the action lies. And
So, Ettienne, thank you. That was excellent. I just wanted to ask, how open are your patients to this? Because I find even convincing patients to have neoadjuvant chemotherapy where they're triple negative or HER2 positive is quite a challenge.
I think it's about how you communicate that to the patients. So if I talk to the patient, I say, this is our bag of tools that we have available. So it's about how we talk to patients, and I think we need to retrain. Again, I come back to the surgeons who often still see the patients up front. I think if the patient sees the oncologist first, the patient expectation is, I'm going to have chemotherapy or radiation or whatever. So that's what they expect to hear, and if they hear that, they're happy. If they see the surgeon first, they say it's a surgeon, the surgeon's going to do an operation, they expect to have an operation first. And in the patient's mindset, it's still treatment of breast cancer equals, I don't want to, mastectomy frequently, but let's say surgery. So when I see the patients, or I do make a concerted effort. Number one is that most of our patients, I've changed that they don't see me. So even if the referral comes to me, I will triage the patient and I'll say this patient sees the oncologist first. So I think that's the first thing. The second thing is, when I talk to them and say, this is our bag of tools that we have for breast cancer. We need to decide which tool set we're going to use for you in terms of your cancer, and we might change our mind as we go along. I always start with the words, if we are going to do chemotherapy, we must do that first. So then I start explaining to them. The second thing is, when I say, well, we're going to need a genetic test, so we're going to have to wait for stuff to happen. Then it's like, and they say, but don't worry, we are going to start killing your cancer right from the start. So then they're very happy, because the doctor's not waiting for stuff to give me some more bad news. He's actually killing the cancer already. And then I explain to them that it gives me, I use the Russian analogy. I say, we are launching a preemptive missile strike, and we need an opportunity to send the drone to go and have a look and see what's happened. So I find it's the way we communicate with patients in terms of, and the expectations. So when the patient phones in, the first thing they hear is to say, ma'am, don't worry, we'll manage your cancer for you well. we have got a team of people that's going to look after your cancer, and we're going to try and start doing things within the next 24 hours. So patients already feel like something is being done. It's not a matter of, I'm waiting to see Dr. X somewhere, he's going to or she's going to do an operation. So I think we need to change our narrative in the way that we communicate with patients. And I find almost no, in fact, patients are very happy. My experience is they're very happy with that approach. I don't have patients that say, but what about, what if? They're not concerned about the fact. So, and then I come back to, no one's ever died of a lump. You die because cancer cells send little seeds into your body that's going to grow elsewhere. That's what's going to kill you. How do we kill those seeds? By giving you stuff that goes throughout your whole body. So I try and enforce that narrative that the treatment of breast cancer is not removing a lump.
Lisa.
Thanks, Ettienne. That was great. So my question hinges on Britta's. How do patients feel about having a repeat biopsy, first of all? And second of all, do you do it 2 to 4 weeks? And do you do it for everybody? So it's not something we are doing routinely for our patients in our clinic. I suppose there's that group of elderly patients that you're kind of putting on hormones, you're monitoring them clinically, like you say, months to come. But the patients that you're perhaps being a bit more active on, I'm assuming those are the patients you're doing 2 to 4 weeks. And yeah, are you doing that? And then how do the patients feel about another biopsy?
Yeah, so it's typically a patient that I want to make a decision whether we need to swap to chemotherapy. So firstly, it's not the T1s and T2s that come along. They are patients that are going to be on endocrine therapy. I don't really care so much about what happens to the tumor. I just need time to get through all their stuff. I'm going to operate them and they're going to have that. Okay. It's in other words, a T2, sort of a large T2 or a T3 tumor, or maybe a T4B. Those are big tumors that you can generally clinically palpate. And they generally would be, secondly, they have high proliferation. They maybe have a low PR, so I'm worried about a tumor that might be a luminal B. And I want to try and make that decision. So those patients, I'm going to start off on endocrine therapy and I'm going to re-biopsy. And because they've got big tumor, it's a biopsy that I can do in the rooms very easily. So the patients don't have to go to x-rays and have a whole big shebang for that. So it's generally easy to do. So we would routinely, that group of patients, high Ki-67, aggressive looking tumor. And what I'll sometimes do if I'm not sure is I'll see them at 4 weeks. And if the patient already has a very big clinical response at 4 weeks, because I sometimes see that it's halved in size in 4 weeks. For me, then I'm not going to repeat the biopsy because it's showing me that it's responding really well. So I would probably say in that group of patients of mine, maybe about 20% of them will get a second biopsy. But the patients are generally quite happy with that. We do it, in a kind and caring way.
Yeah, a couple of remarks about what was said. Britta, I think you have very funny patients. Generally, it's only 5 to 10% of patients or less that actually refuse the doctor's recommendation. These are international numbers. On a more serious note, for the premenopausal patients, I've got a problem with the data that seem to show that you can, without loss of efficacy, add chemotherapy to endocrine therapy. I don't know why. Because my interpretation is, and that was borne out in a recent pooled analysis of the data, that there's no difference in between neoadjuvant hormonal therapy and neoadjuvant chemotherapy for premenopausal hormone receptor positive patients that fall in defined categories. And my suspicion is that the lack of control of the completeness of ovarian suppression in some of these endocrine-only arms of these studies may have led to a bias that is introduced here, where the chemotherapy in the other arm actually completed the ovarian suppression, and that led to a seemingly improved response. And I think if we're doing hormonal therapy, neoadjuvant or adjuvant in the premenopausal patient, we must actually look at the completeness of ovarian suppression. Thank you. And a last remark, what we, harking back to the 1990s when we wrote Letter 024, the thing that we learned was actually that 4 months of neoadjuvant endocrine therapy is absolutely not enough. Minimum is 6 months. Minimum.
Yeah, well, I think, again, at St. Gallen 2021, there was a big discussion about sort of the premenopausal patients in the neoadjuvant setting in terms of the endocrine ovarian suppression, like Jester says. And in fact, the consensus was that if you start a patient, especially if you're going to do 3 monthly injections, the patient needs to have an hormone profile done before each injection to check that their ovarian function is being suppressed adequately. And there are some of those patients that escape in between that should actually have more frequent treatment. So if you're not going to do an oophorectomy, then you should really be checking these patients' hormone status in between their suppression therapy.
What about side effects in those patients? I've heard via the grapevine that, those premenopausal patients that you give that dual treatment to get really, really bad side effects.
The reality is, if a premenopausal patient is on chemotherapy and she doesn't get postmenopausal side effects, I'm very concerned about whether the treatment is effective. So, in my mind, it's what is our aim? Unfortunately, I always tell patients it is going to cost you something not to die of breast cancer. You are going to have to sacrifice something. One of those things that you're going to sacrifice is premenopausal status. We can't allow, we see that frequently. If you treat a patient and you allow their ovarian function to sort of pop up every now and then, those are the ones that get recurrences. So it is vitally important that in these patients, if you want to treat them effectively, systemically, you need to make sure. So yes, they are going to have side effects, but they are going to have those side effects regardless of whether you're adding the endocrine therapy or not. You're just making it a little bit more effective and more predictable by adding it to the chemotherapy.
Okay, any last questions? There's one more there.
Thank you for that very nice presentation. So about the endocrine therapy, I don't have much experience with these patients because even the little that I've seen is in the postmenopausal women. But I would like to know what is your take on women that you have given endocrine therapy on, especially premenopausal, because you're saying you've given it to some of your premenopausal patients. How do you monitor the response? Because I've seen it could be a luminal A or a luminal B tumor. Then you give endocrine therapy to these patients, and in some of them the response rate is really good. So maybe after 6 months, if you do an ultrasound or the way you're saying the Ki-67 levels, they have dropped and then they become candidates for surgery. But there are those who are still luminal A or B and you've given endocrine therapy to them, but after assessment, maybe 3 to 6 months down the line, the response rate is not so great, but it is responding. So do you feel like when these response rates are not so good, you're giving a chance to the tumor to spread into maybe the lymph nodes or distal even?
My understanding of breast cancer is that the patient has metastatic disease or not at the date of diagnosis. You don't develop metastases 6 months after you've been diagnosed on treatment. So these patients, these luminal A's and B's have a long lead time when they have cancer that are subclinical, and that's the time when the tumor has the best opportunity to spread. So if I'm doing staging investigations and there's nothing to be seen, it doesn't mean that the patient doesn't have metastases, it just means I can't see them. That's why we are giving people adjuvant therapy, because I don't know whether they have micrometastatic disease or not. There are lots of trials looking at circulating tumor DNA and stuff like that. So So in my mind, if I have a premenopausal patient that I would want to treat on endocrine therapy, which I would do, I think those patients may be more important to do that rebiopsy and check the Ki-67. It's important that you ensure that the patients have good ovarian suppression. So I think that's essential. I see the patients in the beginning every 4 weeks. And I want to be sure that for the first 2 to 3 months that I'm seeing a consistent response. As Francois said, they often don't, sometimes they shrink very nicely, but often they become vague. They become less predictive. And that also means that you don't see them as well in ultrasound. I find frequently if you do ultrasound, it almost overestimates the tumor extent. So it's difficult to do. MRI, remember it's different. MRI has been well established in neoadjuvant chemotherapy, but in endocrine therapy, not as much, because you're not getting acute tumor necrosis and stuff like that. So you're getting this very slow process, and even though sometimes it feels like the area has become stable, you still have a response. So my approach is very much to trust that proliferation drop. If I treat the patient and 4 weeks later the rebiopsy says proliferation is down to 5%, I trust that, and that is unlikely to change and all of a sudden jump up again. In all the data, that doesn't seem to happen. And obviously, at some stage, I'm going to operate that patient, and I'm going to see whether that proliferation has changed again. But I must be honest, I have even in, there's a few patients that get sent back to me and say, but we think this patient's progressing, that the tumor is getting bigger. My experience is generally it's not the tumor getting bigger, it's the immune response around the tumor that is becoming more prolific, and that's what you're feeling or seeing on the ultrasound. So I trust the biology of what I'm seeing, not the morphology of what I'm dealing with. I hope that answers the question.